Refractive cataract surgery in Ectopia Lentis using digital marking system. This patient had two diopters of astigmatism with steep axis at 127 degrees. A 22 diopter EDOF Iol was planned. A Hoffman pocket was created on the steeper axis and two 2.2 millimeter incisions were taken opposite to the Hoffman pocket to neutralize the two diopters of astigmatism. This is the marking, digital marking for Hoffman pocket. 40 degrees Hoffman pocket was marked, and the Hoffman pocket was created with the help of a crescent blade. The depth was chosen to be 3.5 millimeter from the limbus, and with the help of crescent blade, the pocket was created till the 3.5 millimeter mark side port incision, and the AC is filled with cohesive viscoelastic, and uh, 2.2 incision is made, and a small capsular puncture is made with the help of 26G needle. The puncture is extended with the help of a micro Caesar, and with the help of Aldi precursor forceps, the capsulotomy was initiated. And then I realized that the subincisional capsulotomy was quite difficult. So I decided to create the capsulotomy with the help of a 26G needle from the side port. It started extending to the periphery. So the incision was enlarged with 2.2 millimeter blade, and the capsulotomy was completed with the help of the precursor forceps. Then cohesive viscoelastic was used to dissect the cortex from the capsule, and two iris hooks are implanted to support the capsule. The second hook is introduced into the capsular bag, and then adequate stretch was created and hydrodissection was performed with the help of BSS, and then coaxial eye cannula is used to aspirate the nucleus and cortex. This was a 13-year-old patient. The surgery was performed under general anesthesia. The lens hooks are holding the capsular bag very tightly and nicely. Before removing the irrigation handpiece, cohesive viscoelastic was injected into the anterior chamber to keep it formed, and the remaining cortex was aspirated with the help of dry aspiration. The hooks are slightly loosened, and the CTR is introduced into the capsular bag. The hooks are taken to the side, and CTR is adjusted into the capsular bag with the help of Sinski hook. The hooks are then removed one by one by slightly tilting it. The hook very easily comes out if we tilt it properly. The second hook is removed, and the remaining cortical tag is removed with the help of dry aspiration after putting viscoelastics into the capsular bag. This is the marking for reintroduction of needle 2 millimeter from the limbus and 1.5 millimeter apart. This is the Gupta segment. Its eyelet is threaded with the help of 9-oproline. The wound is slightly enlarged, and the Gupta segment is introduced into the capsular bag and adjusted into the capsular bag with the help of Sinski hook. Then the needle of the prolene is introduced into the anterior chamber. And this is the 26G needle, which is guided into the vitreous cavity first, and then it is lifted into the anterior chamber. The 9-proline needle is then railroaded out with the help of 26G needle through and through the Hoffman pocket. After externalizing the first needle, the second needle is introduced into the anterior chamber, and then it is railroaded out again with the help of 26G needle, which is first guided into the vitreous cavity and then up into the anterior chamber. The needle was properly guided into the lumen of the 26G needle, and then it was externalized, and then the loops of the both the threads are externalized with the help of Sinskey hook. First loop is externalized, then the second loop. Then the loops are cut with the help of a conjunctival scissor, and three knots are tied at just to adequately pull the Gupta segment into the position. This is the second knot, again the third knot with three throws, and the last knot with single throw. The threads were cut off, and EDOF Iol was introduced into the capsular bag. It is adjusted into the capsular bag so that the haptics are in the region of the zonular weakness. The cohesive viscoelastic is aspirated out, and coming to the first post-operative day, patient had 618 unaided vision. I had to take one suture in 1 month post-operatively, properly centered IOL into the capsular bag, and the patient had best corrected visual acuity of 6.9 and NA partial with 0.75 diopter cylinder at 115 degrees. Thank you for watching.